Other denervation problem is gastroparesis. Its incidence is usually around 5%, most commonly seen after a patient having a diabetes mellitus, and more with Roux gastric reconstruction than Bile 1 and 2, because there will be disruption of the intestinal denervation, and it is always disease diagnosis of exclusion, because there can be some microperforation or some adhesions which may mimic the gastroparesis. And vagal denervation diarrhea incidence is around 30%, but clinically significant only in 10% of the people. So most commonly it is due to damage to the celiac branch of vagus nerve, but other causes are like bile acid malabsorption, bacterial overgrowth, or gastric gastroparesis. All these may mimic the vagal denervation diarrhea. And gallstone formation can happen because there can be damage to the hepatic branch of the anterior vagus, resulting in the decreased bile stasis. And because we are diverted the nutrients into the jejunum, diverting the duodenum, resulting in loss of cholecysteine release into the duodenum. These two can cause the gallstones. Next is afferent loop syndrome. Afferent loop syndrome is most commonly caused by any anastomotic stenosis at the GJ site, or volvulus, or adhesions, or kink angulation, or internal herniation. So it can be acute or chronic. Acute onset usually sudden onset of right upper abdominal pain, nausea and vomiting, and chronic will have postprandial epigastric pain with distension, and episodic bilious projectile vomiting will result in the symptom relief. Efferent leaf syndrome also similar to say afferent leaf syndrome, where kinking, adhesions, or anastomotic stricture may cause efferent loop syndrome. It is usually present with the periumbilical cramping type of abdominal pain, like our obstruction, where large volume vomitus containing bile and food. And bile reflux gastritis more with the Bile 2 than Roux reconstruction. So Roux reconstruction prevents the bile reflux. So there will be abdominal pain and bilious vomitings, but the pain is not relieved with the antacids in bile acid reflux, and pain will not be relieved after vomiting, as unlike afferent loop syndrome. Another is jejunal-gastric intussusception. There are multiple types. One is afferent limb intussusception, efferent limb intussusception, combination of two, or type 4 in both this intussusception through the bronch side-to-side JJ. Clinical presentation will be like epigastric pain, vomiting, and palpable epigastric mass. This is the triad of this one. And etiopathogenesis can be because of postoperative adhesions, or retrograde peristalsis, or shortening of the jejunal mesentery, or large anastomotic orifice, or jejunal stenosis, or long afferent limb. So there will be on CT imaging, there will be whirlpool sign, where jejunum is, we have recently operated this case. So it is a case operated 10 years back, GJ. So total jejunum intussuscepted into the stomach. You can see target sign or whirlpool sign. Now next is Roux stasis syndrome, because we divide the jejunum. So divided jejunum gets separated from the duodenal pacemaker cells, which results in the abnormal peristals, ectopic pacemaker cells in the Roux limb, which have both propulsive and retrograde movements, which results in the Roux stasis syndrome, which can cause abdominal pain, abdominal distension, bloating, and nausea and vomiting, which most commonly seen with large gastric remnant and after vagotomy. And marginal ulcers are seen when we exclude the antrum from the during the resection. If there is an antrum is retained, there will be pooling of the retained antrum in the alkaline content of the duodenum, which results in excessive gastrin secretion, results in the marginal ulcer formation, whether it is Bile 1, Bile 2, or Roux limb. Last one is the nutritional deficiencies, where we can see most common deficiencies are iron, vitamin B12, folic acid deficiency, and vitamin D calcium levels. So anemia post-gastrectomy, we have to evaluate for all the multivitamin deficiencies. So there can be multiple pathogenesis for the deficiency of gastric symptoms. It can be because of dumping, reduced intake, reduced transit, or bacterial overgrowth, or intrinsic factor deficiency, or if there is any occult bleeding, which results in anemia, osteomalacia, and malnutrition. So this is our organization TAC. If anyone wants a membership, please contact these numbers. Thank you.